Hi, everyone. This is Dr. Ukarapong, or everybody call me Dr. Book. Um, Today, I'm just going to talk about growth and abnormal growth in pediatrics. This is part one of the lecture that I'm going to be recording, and you guys are going to be watching it before the academic half day this Thursday. So the reason why I'm doing this because um, we have a new format, which is an online. So I'm not sure how it's going to work out. So I think we'll start by some video, so you can do the study before the actual academic half day. And there's going to be a little bonus because we'll be playing a quiz, um, an online quiz, the very first online quiz, and some of the answers is going to be on this video, so pay attention. All right. So the first thing we need to understand abnormality in growth is that we need to understand growth chart. Remember, this is the only tool that endocrinologists have. We don't have echocardiogram, we don't have pulmonary function test, we only have growth chart. So it's pretty much essential. So many of you have seen this growth chart, whether it might look a little different or in a different format, because I believe you guys have either Cerner or UChart, and both of them have electronic growth chart, but it's the same principle. So some of you are quite overwhelmed by all these lines, right? The numbers. I want to tell you that the growth chart is nothing but statistics. It's statistic and statistics. So each line represents the percentile. Compare to the other children at the same age, right? So if you see somebody here at 9 years old standing at a 50th percentile, that means it's a 50th percentile compared to other children, same sex, at the same age, right? So this is done by CDC, right? You might be familiar with other form of growth chart or WHO growth chart, but the one that we use commonly is by CDC. Okay, so what do these lines represent? So it represents a percentile of growth or percentile of height distribution at each age. Okay, so I'm going to break it down step by step. Once you understand all what these lines are, it'll be a lot easier for you to understand the growth chart. And remember, we talked about the difference between CDC and WHO, not so much different after 2 years old. But before 2 years old, the WHO growth chart and the CDC a little different because CDs are done in the United States and many of United States baby are fed by formula. So there's a difference between the breastfed and the formula fed. But just for the simplicity, we'll just stick with the CDC. So again, if you go back to the normal distribution, it will make the graph looks a lot easier. You may notice the 95th percentile, right, on the growth chart, which is corresponding to 2 standard deviation above the mean. You may also see a 5th percentile, right, on this side. 5th percentile, which meaning that it's 95% below the rest of the curve, right? So this is corresponding to the 5th percentile. Now 68, remember, 68 divided by 2 is 34. 50 plus 34 is 85th, 84 to 85th. So that's corresponding to 1 standard deviation, right? You may not see the 85th percentile line, but that's actually the +1 SD, okay? So what do? So they bring all the children at age, for example, age 9, and plot all of those height, right? And then you're gonna get a normal distribution curve like this when you collect all this data of all normal children at 9 years old, boy or girl. Then they have two different distribution curves, right? So what does it look like? We flip the curve, right? So once we flip the curve, this is our 0 SD, which is 50th percentile. This is our +1 SD, which is 85th, +2 SD, which is 95th, right? And third percentile +3 SD is 99th percentile, right? Same way in the other direction, right? So -2 SD, 5th percentile, right? So this is for one age group, right? So if you plot the other age group, right? For example, this is 9 years old, this is for 10 years old, this is for 11 years old. You're gonna get a chart, an outline that looks like this. Once you connect the dot, right? So you connect all the 50th percentile together, you're gonna get one line. You connect the 95th percentile together, you're gonna get another line. And then you connect the 5th percentile together, you're gonna get another line, right? So does this look like growth chart? It starts to look like a growth chart, right? So again, anytime you see a height on the growth chart, remember, it represents the percentile. Doesn't tell you anything, okay? Doesn't mean that you're on the 5th percentile, you're abnormal. Doesn't mean on your 3rd percentile, you're abnormal, right? It's just tell you where that child stands on the growth chart, okay? Now, you may notice that the lines are not straight, right? It has, for certain period, it is straight. Certain period, it looks kind of like slows down. Certain period looks like it is very steep, right? So what do those represent? Is corresponding with a growth pattern, human growth pattern, right? We don't grow at the same rate all the time. That's the reason why our growth chart looks like this, right? So remember, you guys have memorized these before, right? The rate, the growth velocity during infancy, right? So there are 5 stages of human growth patterns, okay? First 2 years, first year of life, very, very fast. Like remember, like when we used to remember, like during nursery, rotation, that is, you double the height within certain months, right? So it's average about 12 to 15 centimeters per year. You'll never get a growth rate that high ever again in your life, right? So this is the time that your growth velocity is the fastest, okay? Then it starts to slow down after 2 years, right? The growth in the first 2 years of life is independent of hormone action. Why do we know this? Because kids with growth hormone deficiency often have a normal growth velocity in the first 2 years. Then what happened after that? It has a steady rate during childhood, right? So you're gonna see that the graph looks pretty straight, right? So those corresponding to a very steady rate of growth during childhood, right? If you remember math, calculus, the delta growth velocity is 0. The difference between growth velocity during childhood is almost 0, but they're not growing at a 0 centimeters per year, right? They're growing at a steady rate during childhood, right? Then what happened? It picks up during puberty, right? This is what you call the growth spurt. It's accelerating during puberty, right? And then it plateaus after puberty complete, right? So the graph become flat, right? After your puberty complete, okay? Now, We're going to be talking about puberty in a second lecture, right? Because there's some variation in the timing of puberty, right? But on the average, boys is about, the peak growth velocity is about 14, right? I'm talking about peak growth velocity. We're going to be talking about it again during puberty. But you don't get to peak growth velocity within just 1 year. It takes about 2 to 3 years to get to that peak growth velocity. So when you see a boy at 10 or 2, you may not see rapid growth yet, right? It occurs during mid-puberty between 10 or 3 to 10 or 4. Now girls, so remember, always 2 years ahead of boys. So that's why when you look at girls, right, go back to what I talked about earlier, 5 stages, right? This is already past the 2 years, right? So during childhood, this graph kind of look flat, not completely flat, right? But it has a pretty steady rate of growth, right? And if we look at here, right, remember the third percentile, right? So bottom of the curve, it's about between 4 to 5 centimeters per year. So that's our magic number. Why we say that during childhood, anytime you have growth velocity less than 4 to 5 centimeters per year, you may have a problem, okay? And then look at this very, very, very fast rate of growth, right? This is peak growth spurt, which occur, again, averaging at 12 years in girls, right? This is corresponding to tenor, tenor stage 3 to 4, right? And then it slows down after that, right? So girls, by 14, they're almost finished, right? And these two dots corresponding to girl with precocious puberty or delayed puberty, right? The curve shifts, right? So if you think of a boy, it'll be 2 years shift to the right, like this, right? So this is for boys, right? It peaks around 13 to 14 years, which corresponding to mid-puberty. Yeah. So now we understand the growth chart. We know what those lines are. We know how to calculate growth velocity. Again, calculating growth velocity is simple math. How many centimeters you grow in what certain period of time, and then extrapolate it back to per year, right? Now, the most accurate will be measuring height between 2 time point 1 year apart, but we don't do that, right? Because we see our patient more often than once a year, okay? So what do we do when we first look at a growth chart, right? You're gonna get many residents are overwhelmed by when you look at growth chart, right? So these are steps that I recommend, okay? First, we talked about it. We look at the percentile, right? What is the percentile, right? Again, being on the third percentile does not mean that this is abnormal, right? If it does not look right, remeasure, right? And I'm going to be asking you on the quiz, what's the name of this plane? It's called Frankfurt plane. It's a normal, it's a correct head position, right? So that means an imaginary line between the middle of the earlobe, right, which is actually external ear canal, is in the same line as the bottom of your eye socket, right? So this is called Frankfurt plane, right? I'm going to be asking you on a quiz, so take note. And then what do we do, right? Remember, what do we do? We're clinicians, so we review history, we look at physical examination. It's very important. Cannot diagnose a growth disorder without careful history and thorough physical examination, right? It will also include pubertal exam, which we're going to be talking about in a second video, right? Because if I'm talking about a 13-year-old who's 10 or 2 versus a 13-year-old who's already 10 or 3 to 10 or 4, it's a different story, right? So careful history, physical examination, and then calculate growth velocity, right? like we did before, right? So here's an example, right? So you see a 10-year-old boy, 10-year and 1-month-old boy, that his current height is 140 centimeters. And you review his growth chart, okay? This is gonna be some problem. Sometime you may see the patient for the first time, so you may not have previous history, but the best way is to try to obtain it or try to ask the parents, like, do they think the kids are growing slower? And worst come to worst, we may just have to observe how patient grows for the next couple of months because we don't have any previous history, but try first, right? And remember, anytime you see something that is really, really off, for example, if you see a patient that is on the -4 standard deviation, this may herald a real problem, right? So it's a very, very abnormal standard deviation, right? Otherwise, it's really hard to say whether a patient has a growth problem or not, okay? So in this case, you were able to find a history, and at 8 years and 2 months, the patient was 131 centimeters. So how do we calculate growth velocity? How much did the patient grow? 9 centimeters over 23 months. So 9 divided by 23 times 12. So it's 4.7 centimeters per year, right? So we already know where the boy is standing, what percentile, what's their growth velocity. Now we can have a conversation, right? So then you will ask history, perform physical exam, right? To make sure there's no obvious physical finding, right? Many people talked about, the familial targeted height, right? So it's an estimation. It's not a God-given number. Doesn't mean that your mid-parental target height is on the 50th percentile. You must have a final height at 50th percentile. They're, plus minus 2 to 3 inches from the familial targeted height, right? So this is a formula, very, very, very simple. It's the difference between X chromosome and Y chromosome. The difference is 5 inches, right? Or 13 centimeters, right? For example, if you want to plot a father's height on a girl's growth chart, you have to minus father's height by 5 inches and average out with mom's. That's your familial target height. On the opposite, if you want to plot the mother's height on the boy's growth chart, you have to add 5 inches, right? So here comes the formula, right? For mid-parental targeted height. And remember, it's just an estimate, okay? So now we have growth percentile, we have history, we have physical exam, we have growth velocity, we have mid-parental target height. After you do all of these, about 80 to 90% of time, you can give some presumptive diagnosis, okay? We're gonna be reviewing cases during the academic half day. So that's why I'm doing this video for you to have some basic before we start reviewing cases and board questions. Okay, now etiologies, I'm not gonna go in details. You have to go and read some of those chronic conditions that can cause short stature, respiratory, very common, cystic fibrosis, cardiovascular, complex heart disease, kids with complex cardiovascular disease, they don't grow well, GI, malabsorption syndrome, irritable bowel syndrome, sorry, inflammatory bowel disease, not IBS, chronic renal failure, hematologic, like either heme or oncology, neurological, cerebral palsy kids, they don't grow well, right? So it has a long list of etiologies. Okay. Now, genetic disorders, a very, very big umbrella. It could be chromosomal abnormalities, inborn errors, metabolism, or skeletal dysplasia. Now, I'm going to be talking a little about skeletal dysplasia because it's quite obvious by exam, right? You should be able to pick up patients that have a severe form of skeletal dysplasia because it's not hard to miss, okay? Now, this is the bonus part. I'm going to ask a question about some of these syndromes. If you watch this video, the chance are that you're going to be doing well on this quiz. And just a little bit of a incentive. The winner of this quiz will get $25 gift card. Okay, so Turner syndrome. Board question usually asks something very, very obvious, like prominent clinical features. They don't ask something that requires a knowledge at a specialist level, right? So Turner syndrome, we know it's caused by abnormal X chromosome, either absence of X chromosome, that's 45X. You can have mosaic cell lines, you can have 46XX, 45X, right? Or you can have isochromosome, or you have ring chromosome, right? So the 1X forms a ring. And this form has the most severe developmental delay and cognitive impairment. It's going to be one of the questions. So review prominent features, cardiovascular system, the most common features, bicuspid aortic valve, right? Now, delay endocrine system is going to show up on the puberty because this is a form of an ovarian failure, right? So we're going to be discussing in the second video. It's consider a hypergonadotropic hypogonadism, right? They have short stature. They have other features like web neck, Y carrying angle, and they have one of the deformities I'm going to be asking is called Madelung deformity. Okay. If you want to know what it looks like, you can search it online. Madelung deformity. Now, Noonan syndrome is part of a signaling protein that is called RAS group, right? We call it rasopathy, right? Which is a genetic abnormality involving RAS-RAF MAP kinase pathway. I'm not going to go into details, there's too much details for your board level, right? But again, we're talking about prominent features. Go and read about this syndrome, read about who describe it first. It can be on your quiz. The prominent cardiovascular system is pulmonic valve stenosis. It's not artery, it's pulmonic valve stenosis, okay? They also can have hypertrophic cardiomyopathy, right? Now for endocrine system, remember this is not a sex chromosome abnormality, so it can be involved in boys or girls, right? So they have short stature, some boys have undescended testes, and they have also other involvement in other systems of which you should try to go and review it. It comes up on the board. Now, another syndrome is called Prader-Willi Lapart. Sorry, it's misspelling. It's Prader-Willi Lapart, right? We all know it just by Prader-Willi, but there's another doctor on that a paper. His name is Dr. Lapart. Okay, I'll be asking that on a quiz. Okay, it's an imprinting defect, right? They always ask you on a board question about imprinting defect, right? So imprinting is the difference between a maternal or paternal allele, right? So some gene, one of the allele has to be silent, right? That gene that has to be silent, we call it, that gene is imprinted, right? Now, in this region on 15q11.2, paternal allele is active, right? So it's expressed when that paternal allele is either silenced or mutated. It causes Prader-Willi Lapart syndrome. And that critical region, there's one gene called SNRNP gene that we think plays an important role. It's going to come up on the quiz. Okay, so take notes on this. Remember, we're talking about prominent features, right? So Prader-Willi, cardinal feature is hypotonia during infancy. Okay, so they start off with very hypotonia, they have feeding issues, and then later on, they become obese because you cannot um, stop the appetite, right? So it's at the hypothalamic center, right? So they have short stature, they're obese, and have delayed puberty. So it's going to come up in our second video. This is consider hypogonadotropic hypogonadism, right? So it's a central, it's not the gonads, right? I'll be explaining again during puberty lecture, right? Now the last part, the last one I'm going to be talking about today is achondroplasia, right? This is one of the most common skeletal dysplasia, right? It's an autosomal dominant, right? The gene is called fibroblast growth factor receptor type 3, right? It's an activating mutation. It causes the growth plate to fuse prematurely, right? They're extremely, extremely short. They could be -4 to -5 SD. Once you see achondroplasia, you won't miss it. It's quite striking, right? They have extremely short limbs and they have normal IQ. How normal? This doctor, Dr. Michael Ain, he's an orthopedic surgeon at Johns Hopkins, and he has achondroplasia, right? So they can achieve normal milestones, and they have normal IQ. So I think that's all we're going to review in this video. Again, this video is just some basics, some concepts that we're going to be talking about during the academic half day. I want to do this so that you can review before we start the lecture. Again, go back to look at the growth chart and try to dissect it the way I did. So let me see if I could try to. Okay, so this will be the end of this first video.